Okay, we're going to get started. We have a presentation today basically just on some common courtesy etiquettes of being on the wards, but also something that we think is important to know because we kind of do for no academic or evidence-based reasons. So to start off, Charlene's going to give you a presentation on just some common courtesies and etiquettes that you'll probably encounter while you're as a resident. And then on the end of it, I will speak to you about things that we do for no reason.
So my part is like kind of simple. A lot of it is common sense and common courtesy. So things I like to cover, paging etiquette, like how do I even page somebody? Has everybody paged somebody by now? Anybody? Yeah, show your hands. Everybody? Kind of. Yeah, okay. Did anybody try using the one on like your little manage this one? I don't know what I forgot what it's called, but I'm blanking right now, but have anybody used that? Smart phrase, where you just click on it and you text page somebody? Not yet. Yeah, try using that. It's quite easy to use. A lot of the time, if you can't find anybody's pager number, I know it's very easy when you have the pager number at the back of your badge, but like for those of you who can't find it or don't have your badge on you, this is like a great alternative. Again, if you have a cell phone, paging somebody is 207 followed by that 4-digit number. Landline is also 207 followed by that 4-digit number. For anybody who got a 5-digit page, if it starts with an 8, it's a 778 number where you have to return. And anybody that got a 5-digit number, page back number that starts with a 7, it's 957, and then like whatever that 4-digit. Also the on-call finder. Did everybody find the on-call finder on their Epic? Super useful if you have to page cardiology. Like they switch fellows quite often, and so if you need to find a fellow, you can always use it on the on-call finder. What format should my pages be in? We thought that a lot of the time there's not really a lot of format. As somebody on the floor, you'll get a hodgepodge of like number pages, text pages, and stuff like that. There's honestly multiple methods. If you have, let's say, a consult to call, I just wrote it on there like a sample kind of consult page that you can text page the fellow. New consult, MN is, let's say, like their initials, and the MRN is this. Very quickly, like this 29-year-old male with acute onset chest pain, roll out ACS. Your callback number, which is that 5-digit number, should be on there, or your pager number. 1449 is my pager number, and then Charlene. It's like simple. It tells you what this is, and basically, like you use that for calling consults. It's very easy. For urgent pages, just call like a 5-digit callback number or your cell phone number, and then usually people will get back to you because there's no text to kind of read like what they can do, and they can't triage to say like if it's urgent or not. Makes sense. What do you do if you call and nobody responds to your pages? Has anybody encountered that? Amy's smiling. Oh. Yeah, so actually, like a lot of the times you get really frustrated. You page like the GI fellow, and the GI fellow doesn't page you back, and you're just kind of like sitting at the phone waiting for the pager, like waiting for the phone to ring. I think like, you know, if you put yourself in the shoes of somebody else, like, you know, that GI fellow might be rounding on a patient. And might be actually like in the middle of a soap or kind of busy. So what I want you guys to do is like kind of contextualize. If this is a consult that you need to call, if you text page them this consult, it allows them to actually triage and kind of call you back within like 5-10 minute kind of thing versus like call you back right now. Did you give them enough time? Did you give them like 5 seconds before repaging them? Did you give them like 5 to 10 minutes before repaging them? And then like if you think, okay, it's already been like 10 minutes, nobody's paging you back, page them back again. Like they should return your page within like a 5, 10, 15-minute kind of time span.
Not repage them.
Yeah, don't repage them. Because if you think about it, because nurses will page you all the time. How would you like it if you get hammer paged every 5 seconds to the same number? Like you would absolutely hate that. So kind of like, give the fellow some leeway. When should you respond to your pages? So do them the courtesy, be the bigger person. Respond to them as soon as you can. If you're in the patient room and you don't, that's why text paging works very well. If you see like text page and you're like, okay, well, this is not somebody who needs a melatonin at bedtime is different from, let's say, like a crashing patient. So we encourage you to text page as much as possible. Paging somebody a number, to me, like especially if I get it at night, means that I have to call them back as soon as possible because I don't know what's going to go on at the other end. It could be just, hey, can I have some like Olays, which Mintry will go into, for like constipation in the middle of the night, or it could be a crashing patient. So usually for me, if I get like a 5-digit callback number, I page them back quite right away. Or if I'm in a patient room, I tell them, hey, sorry, I just got paged. I'll be back within like 5-10 minutes, but I really need to answer. Then usually they're like pretty understanding that you need to return the page. And always like kind of contextualize. If you get a text page for like, I always think Colace because I got paged that so many times that night. But like something for constipation in the middle of the night, you don't have to step out of the patient room if you're doing it. You can just like kind of reply back to them. It'll be fine. So how do I stop the nurses from inappropriate paging? So a lot of the times, and this will happen a lot at night, where you get paged, and I've had kind of interns and myself, you kind of look back on a 1 hour time span and you get paged 25, 30 times in a row within the one like last hour. And they're all mostly to 1 or 2 numbers. So if you actually find yourself in that position, feel free to just like, I do it in person is a lot better than over the phone. Usually you can find a specific and tell them like, hey, I'm having a really busy night. If this is like important, I want you to page right away. But, if this is something to do with like medicine orders, would you mind please grouping your pages and like not page me every 5? Usually most of them will understand and then they'll group page you, or they'll just page you to one number and then a bunch of nurses will like talk to you at a thing. But also on the other end, this is for night, but like when you're on the day team, like what you can do, because a lot of the pages you get overnight is about like lab orders. Do you want to order this lab? As a day team member, please order any of the labs that you need for the next day. It helps out your night resident a whole lot. And leave good notes. The nurses, believe it or not, actually like read all your notes. It's actually kind of semi-humbling because like they'll be like, oh, this doctor says to do this, and you're like, oh, that's me. But yeah, so they'll read all your notes, and if you leave good notes, it clarifies it for them as well, what needs to be done so that they don't call you or they don't call your night resident and ask what the heck you're doing with the patient. So I left like kind of a kind of sentence or a format that you can use when you get hammer page. Thank you for the page. However, for like something like this that's non-emergent, I would really appreciate if you can batch or group all the orders or group all the pages and orders together, and I do them like once at a time. And most of them are very accommodating for that.
Now, because we have that messaging like system using the Epic, that a lot of nurses start using the message, give you a message, like probably like easier for non-emergent like all the
I guess in one of the surveys,
Yeah, good question. So for the Epic stuff, never use that for paging. So if you need to find a fellow on Epic, find it and find the pager number, but don't page or message them through Epic. Because Epic, just like, if they're not on Epic, they won't see it. And so whenever you page a fellow for consult, you always want them to call you back and confirm that they've received the consult. And we'll go into that a little bit detail. But basically the two ways you can tell that they've confirmed or accepted the consult is one, they call you back and say, okay, we'll see them, or two, they started a note. Or somebody from the team started a note. That's when you know that, okay, the consult's been called, they're doing it. But don't page a fellow on it. That's the bottom line. You can, yeah.
The chat.
The chat. Yeah. Don't use the chat function. What you can use the chat function for, and I've used it multiple times, is something's not very important. You're kind of like, oh, hey, I ordered a 4 p.m. VMP on this patient. Would you please make sure that it's drawn to the nurse? Or like, hey, we're waiting for walking pulse ox results. Have you done that? Or like something like that, then you feel free to like just message the nurse about.
So the chat feature is really good for people who are going to be stationary at a computer on Epic pretty much a lot of, for the majority of their day. So your nurses will often be stationed in an area close to their patient, but even they will go into their patient's room and miss a chat. So don't chat with them for something urgent, go find them. But more often or not, you will get chats on Epic from your nurses, from social workers, etc. If you're trying to find a fellow, guaranteed they're probably running around trying to see all their consults. Chatting with them through Epic would mean that they would have to go through their haiku on their phone, which they may or may not have, and they may or may not have notifications with haiku either. So paging is the best system as of this. I know it's very archaic, but at this point, it's probably the best way to reach fellows and consults.
I think we talked about this a couple days ago, but can you please update the family members? They're here. So overnight pages, this is one of the things that I don't like, where I have to go and update family members, because there's no way that I know like all these 32 patient history off by heart. So feel free to kind of say like, tell the nurse that, because the nurse will ask you that. And if you're not busy, you can quickly chart review and go to the patient family if you feel comfortable updating them. If not, you can always tell the nurse, thank you, but I'm just the covering provider for this patient overnight. Not familiar with this patient. However, I can get the day team to call the family member for updates when they return. I feel like as a family member, if my family member is in the hospital, I would want to hear from the day team who's actually managing the patient rather than the team that's just covering over. So both are options that you have available to you when you're the night resident, and feel free to use one or the other based on how busy you are. Sign out and off. We keep hammering you guys about this, but don't sign up procedures. No senior wants to walk into like 3-4 admissions and like 2 paras. Don't sign out family meetings. Like these are really heavy discussions about usually like end of life code status things, and you do not want to sign that out to somebody who's not familiar with the patient. Don't sign out a decompensating patient. Usually as a senior, a lot of the times, like I will stay and make sure this patient is managed well, and like at least disposed well. If this patient's going to step down, then I'll make sure that this patient, at least all the transfer note is done, the teams have been notified. And so what you can do on your part is to make sure that the transfer note is done and that the teams are all notified before you kind of leave. And then don't sign out discharges unless they're already like order rec and the meds to beds are called for them. We do service a vulnerable population and we have this meds to beds available for them that somebody's going to deliver all the medications to their bed. So make sure that if these patients are going to be sent home with some new medications, that the meds to beds are done for them. And again, if you're signing out a lab or an imaging that needs to be followed up on, make sure you sign out like, if this was positive, what do you do? If this is negative, what do you do? Otherwise, if it's not important and if there's nothing that you have a positive or negative what to do thing, you can always just follow it up in the morning. Okay, paging versus texting. So you guys all have our numbers. Texting and paging us, we're available pretty much like 24/7. But for us, like, I think if it's an emergency, we want you to call us is better, or best. If this is an absolute emergency, call us. Not really emergent, call, text us is fine. But if it's like not really emergent at all, like something about scheduling down the line in a month or 2 weeks, schedule swaps, any schedule requests, stuff like that, we prefer email. This also lets us like triage. Like when you call us or text us, we might be in the middle of a meeting or doing something on the floors. This lets us kind of triage how important it is, and then we'll get back to you as soon as we can. And then calling or paging the attending. A lot of the times the attending actually wants to know what's going on. This might be more of like a senior's job, but as an intern, you can always text the attending, especially sometimes when you're on a per call and it's only you, senior, and the attending. And there will be times where it's just you and the attending. Yeah, and so a lot of the times you can just be like, hey, do you want me to text you if there's anything or call you, which would you prefer? And most of the attendants are amenable to all of them and they want open communication. So ask if you ever are in doubt. Okay, and team dynamics, I just put a picture here. It's basically, I want you guys to like help each other out. As a, like when I worked like as an intern, I remember like whoever was post call and I was on long, I would do sign out. And then the all the other teams, the day person will do consults. So make sure you kind of, before the overnight resident signs out, you kind of, tag team each other and say, hey, I'll do sign outs and you do consults or you call consults. That way you get your team member out as soon as possible because it's tiring to do an overnight call and you guys will all have to do overnight calls. So you want to be there to help out your team. And this happens for step down as well. So, break off. Don't forget it's okay to break off from like rounding and be like, I'm calling consults right now, or I'm paging consults. And then one person will update the charts. And then calling consults, usually we do that before 12 p.m. For the people that are being rounded on in the morning. Again, they'll knows that about the consult when they called you back or when they started a note. And that's when like the most concrete confirmation you have. And like I just wrote in here kind of like a standard consult request. You can kind of spruce it up however you like. For example, if I'm calling consult, I'll just say, hey, I'm Charlene. I'm one of the rounders on 9, calling about Miss X who came in. This is her MRI. MRN. She has a past medical history of this. She came in overnight for new onset heart failure. And then we would like your recommendations for further management. This gives a clear kind of question on what you need to ask or what the consultant needs to do. We want their further recommendations on the management of insulin content. And then just have like simple things ready, past medical history. You paid attention in rounds. A lot of the times, like, you know, whoever is presenting, you'll hear about the past medical history and you hear about like why and what brought them in. That's enough. And because all the rest the fellow can do chart review by themselves. And then room number, because they'll ask, like sometimes they'll ask, what room is that? Like the basics of calling consults. Oh, and that's it. We're on the fun part.
Okay. So you guys can see the screen. So I'm going to do something and try to be interactive here. Let me see. If you guys could text something to a number for me, I'm going to try to do this a little bit interactive so that you can actually answer with your cell phones. If you go into a text message and you type in 22333 as the number, text Metro, METRO, IM 005 and send that. That would sign you up for the poll everywhere. So the number is 22333 Metro IM 005, 005. You guys got it? We good? No. So 22333 is the number that you're going to text to. And the text message that you're going to send is Metro IM 005. No space. Do you have free texting? You should be fine. All right. We're going to talk about things we do for no reason. This has been adapted from several sources. There's actually a Choosing Wisely campaign specific to this topic itself, and there are many more topics within this category. I chose specifically 7 of them. I actually think I took one out a couple of days ago, so my numbering might be a little off. Just ignore it. But I think this is very useful because as interns, you guys will probably be told a lot of different things to do. Order this, do this. Just know that sometimes, you know, you just might have to bite the bullet and order the thing, but kind of challenge yourself with a couple of these facts, which is educate yourself and know what the actual evidence-based medicine is behind why you're ordering these things. My hopes is that when you become fully independent learners and attendings on the floor, that you sort of revisit some of these topics and that you kind of think about, oh, that's right, I did order that, but was it actually the right order and was it a good reason for me to order that particular lab or thing that we did? So we're going to start with a case. This is a 65-year-old man who was admitted with pneumonia. Review of medical record reveals persistent macrocytic anemia. Hematocrit was 29%, hemoglobin is 9.3, mean corpuscular volume is 105 with a low retic count and normal peripheral blood smear. Oh my gosh, I guess you guys can't see this. I think the people on, so here's my question to you guys. What lab should be ordered? So just text to the number that you can text it to. What lab should you order next? I have folate, someone said. Folate, B12. B12, MMA, creatinine, LFT, B12. folate, B12. Okay. I'm getting a lot of B12s, a lot of folates, a lot of T's in there. Okay. So let's talk about this. Folate deficiency. So first of all, folate should definitely only be suspected in megaloblastic anemia. Okay? This person does have an MCV that's above 100, we'll suspect it. But what is the rate of folate deficiency here in the US, and what has been the history of folate deficiency here in the US? Since the 1980s, the 1999s, or 90s, we've pretty much have supplemented folic acid in a lot of the food products here in the US. So grains, cereals, they all have folic acid in them. The prevalence of the disease here in the US is very low. To be precise, it's less than 1.1%. So the deficiency itself is very low. The test itself is also very inaccurate. What you have is a test that pretty much calculates the amount of folate in blood itself. This could also be elevated if a patient just eats a bowl of cereal just before they get tested. We give patients cereal here in the cafeteria and in their inpatient hospital stay all the time. So the likelihood that you're catching a folate deficiency while a patient is being fed breakfast, very low likelihood. The other thing is that if you get a normal folate level, it does not necessarily mean that you have folate deficiency either. So the prevalence here is pretty low. The test itself is pretty inaccurate. The takeaway that I want you guys to have from this is that if you suspect this patient has folate deficiency, supplemental therapy is okay. You can give supplemental therapy, continue to follow the patient, and then consider having them look at a nutritionist and perhaps looking at what things they eat. Maybe there is a folate deficiency concern there, but it's not something that you can just get a lab for in the inpatient setting and expect to have an answer. It is something that you kind of have to tease out. Testing is poor and the prevalence. The second case that we have here is a 55-year-old patient. He has a history of COPD, diabetes. He presents to the emergency room with shortness of breath, leg swelling. This is after a lumbar disc surgery. Emergency department team decides against ordering a chest CT scan with contrast to evaluate for a possible pulmonary embolism after noting that the patient's allergies include shellfish. According to the allergy, it causes urticaria and facial edema. VQ scan reveals heterogeneous perfusion defects consistent with an intermediate probability. Treating physicians consider starting the patient on a steroid regimen to prepare him for a CT scan with contrast, while presumptively anticoagulating the patient for 24 hours in order for the steroids to provide maximal protection against the contrast. In a 1 to 2 word answer, this is actually just kind of for fun. What's your favorite shellfish? Shellfish, like
Oyster?
I think that's a crab, lobster. Oh, lobster is like beating a lot of things right now. Crab is. I wish you guys could see this. Like, you're actually answering right now in live view. Looks like lobster and crab is sort of the. Someone put in an emoji. Oyster, scallops. What's lamsta? Lobster? Lobster. Oh, okay. All right. That's like lobster with Gen Z filter. All right. So let's talk about shellfish allergy and iodine allergy. So it was once thought that shellfish allergy was due to the iodine that's found in shellfish, right? Both have it, shellfish and contrast, both have iodine. But first, serious radiocontrast allergy, it's extremely rare. Again, the incidence here is like 0.1%, okay? There is no evidence to support any association with shellfish itself and actual allergy. The contrast allergy. The allergy that is found in shellfish allergy is actually caused by the muscle filament protein itself. So tropomyosin, as you guys know, that whole muscle sort of like triple spinning sort of myosin filament, that's what causes the allergy in shellfish allergy, not the iodine, okay? So it's very different. Iodine itself is not an allergen. Every single one of you sitting here, hopefully with a normal thyroid, has iodine, right? That's being carried throughout your body right now. So to have an allergy means that something serious is like wrong or different with your body's reaction to it. So the takeaway from this is that don't ask a patient specifically when you're thinking contrast allergies about any shellfish allergy. There's no association. And what you should ask is that if they have any serious side effects to contrast itself, when the patient says, oh yeah, I do have a shellfish allergy, consider that in terms of, okay, well, can you tell me a little bit about that? Who told you about that? Dive a little bit more into the history. It may not be related to your contrast and therefore should not stop you from ordering something to find a PE, okay? We have a 34-year-old male who's admitted for complicated urinary tract infection related to a Foley catheter. He suffers a spinal cord injury at the C4, C5 level of motor vehicle accident about 10 years ago. He's confined to a motorized wheelchair. Engineer, he lives independently, has caregivers. Body mass is 18.5. He reports that his weight has been stable, slight muscle atrophy, reports that he eats well, has no chronic conditions, and that he has not had any GI symptoms. What should you order to check his nutrition status? I have electrolytes, albumin, albumins, prealbumin, nothing. Nutrition consult, prealbumin. All right. Let's talk about this prealbumin. Fun fact, prealbumin is not actually albumin. It's also not the pre-form of albumin. It is literally transthyretin, which you will learn about in 3C and cardiology. It pretty much shunts T4 and vitamin A. And what caused this to be a thing was that in the old studies in like the 70s or so, they showed that there was association with low prealbumin with malnutrition and kwashiorkor. I don't know if I said that right. So after feeding, they found that it increased. So this is the reason why prealbumin shouldn't be ordered for in this scenario. It's a negative acute phase reactant. So anytime you have an inflammatory response, prealbumin goes down. Same thing with albumin, okay? There was a study back in 2015. They looked at non-inflamed state, malnourished patients and found basically there was no change in the prealbumin levels. So here are truly malnourished people and their prealbumin was completely normal. It does not show you that they are malnourished at all. They did note, however, if your BMI started going below 11, that then they started seeing that the prealbumin level is low. I am hopeful that when you guys go and evaluate your patients, that you would catch malnourishment before the BMI gets to 11. Takeaway on this, don't rely on prealbumin or even albumin for that matter to determine nutrition status. Look at the patient, consider a nutrition consult if you really need further to dig deeper into this. Yeah, so this is just a quick, albumin, prealbumin, lots of states that can cause these particular markers to be up or down. And one thing is that CRP can be used to kind of rule out inflammatory states in the setting of looking at prealbumin and albumin. Okay. Next case, 62-year-old guy, he's coming with cirrhosis. Essentially, I'm gonna make this very easy so you won't have to read all of this. He's coming in altered. Question is, does an elevated ammonia level at the admission alter your management? And if the ammonia level was elevated, would a serial ammonia level affect your management at all? Should we check ammonia? And should we continually measure the ammonia level? There's no, you don't have to test for this one.
I just did.
That's cool. I'll look at it later, but I won't. So ammonia levels and hepatic encephalopathy, there is no association here. This used to be a thing because a lot of things that people who are cirrhotic have causes an increase in ammonia, right? GI bleed causes it, renal failure causes it, infections can cause it. These are all the things that people who have cirrhosis come in for. So because of that, we randomly associated hyperammonia levels with hepatic encephalopathy. The problem is when we actually study it, there's no correlation. You can tell me that somebody's ammonia level is 500, 60 something, or like 1,000, and honestly, they'll be the exact same patient. So overall, don't check serum ammonia levels. Do not diagnose with an ammonia level in terms of hepatic encephalopathy. We have our next case, which is a shorter one. This is a 47-year-old man. He has alcohol abuse, cirrhosis, grade 2 esophageal varices. He's treated for alcohol withdrawal. He reports having dark-colored stools a week prior to admissions, but his stool since has been normal. A repeat hemoglobin is also stable. Fecal on-call blood test comes back positive. What should be done next? This one is multiple choice. A is EGD. B is repeat CBC. C is repeat FOBT. D is GI consult. E is none of the above. A, EGD. B is repeat CBC. C is repeat FOBT. D is GI consult. E is none of the above. We're getting 55, 58% of none of the above. We have an EGD. We have some GI consults. We have a pager going off. Okay. All right. Okay, so fecal on-call blood testing for inpatient GI bleeds. Why is this a thing? It's very inexpensive. It's fairly intuitive if you think about it. Oh, they're bleeding, so if I sense hemoglobin in the stool, this patient's bleeding. The problem is that there's just been no supportive data for use in GI bleed at all. The reason why it became a thing is because we use FOBTs for colorectal cancer screening, right? And what does it detect? It detects hemoglobin that could be caused by the cancer itself in the GI tract. And so we then think, oh, well, then I'll just use it for GI bleeds. But then the problem is that it could be falsely positive in many cases, in many scenarios. The other thing is that when you use an FOBT to check for colorectal cancer patient, it's not just one test you have to do several, right? It's actually 3 FOBTs that you have to do in order to correctly rule that this patient needs to go in for a screening colonoscopy. 3 different tests, 3 different times. You're also not accounting for diet. Okay, when in the hospital versus when you're outside, there is a diet component that could change the result of the FOBT. The takeaway from this is use it for colorectal cancer screening. It is one of the options. Do not use it for suspecting GI bleeds in the hospital. Yes? No. Sensitivity for colorectal cancer screening is not even that good. It's like in the 70s or 80s, I think. Okay. 6-year-old guy is coming in, past medical history of obesity, type 2 diabetes. He's coming with myalgias and fevers up to 103.5. Geez. Vital signs are normal, no localizing symptoms, physical examination unrevealing, except for a scab from a tick bite sustained 2 weeks ago. Before admission, he had been managing his diabetes with metformin. On arrival, his blood sugar level was 275. The admitting provider decides to hold the patient's metformin and replace it with a sliding scale. Question is monotherapy with sliding scale insulin the best inpatient management option for this patient's type 2 diabetes? How should we treat, you don't have to text anything on this. Let's just talk about the sliding scale. If you are ever gonna rotate with Dr. Kayas or any of the endocrine attendings, they will hate you for just putting on a sliding scale for their diabetic patients. The reason for this is that it's just not a good method. You're giving them a burst of insulin, and then it falls flat, and you're giving them another burst, it falls flat again. They need basal insulin. Many studies have looked at this, and the takeaway is that basal insulin with prandial insulin is much better at controlling and stabilizing patients' sugars than if you just throw them on a sliding scale. We do it and we love it because it's so simple. You just put in a thing, the nurse handles it. You don't have to worry about dosing it up or down. But overall, it shouldn't be done because it's just not really good for the patient. The Rabbit2 trial was the one that looked at the sliding scale itself versus like a basal insulin and a basal insulin mealtime. There's really no difference in hypoglycemia, so don't even worry about, oh, I'm giving them so much insulin with the basal and mealtime. Sliding scale seems to be more better because it tells me how to dose based on what their sugars are. We're just reactive at that point. All you're doing is you're seeing a number, you're acting to it, but you don't have any idea what it's actually doing in terms of keeping their levels stable. All right, 80-year-old woman, no significant past medical history, presents with mechanical fall. X-rays are notable for right hip fracture. She's treated with morphine for analgesia, and evaluated by orthopedic surgery for surgical repair. Our hospital recognizes that this patient is at high risk for constipation and orders DocuSafe for preventing constipation. Just don't do it. DocuSafe for constipation doesn't work. Multiple studies since the 1950s have shown this, and for some reason this thing, tell your surgery resident friends, stop doing it. We get consults for this all the time, and they're like, help us, what do we do? And we just say, well, give them a real, actual, like constipation treatment, right? So you use Miralax, polyethylene glycol, you use Senna, the Senna or whatever they're called. Lactulose works, but just DocuSafe, just at one point, like the WHO, I think, the World Health Organization made this like one of their like essential medications based off of some pretty poorly studied studies. So since then, it's sort of been touted as like, oh, it works all the time. But then we studied more and more studies have come out since then. It just doesn't work flat out. Some attendance taking. It's like you guys are taking pictures. All right. Guys, that's it. Do you get questions or concerns? Yeah. Sorry if I like bored you and everyone's sleeping right now. You guys can't see in the room, but everyone's just passed out. All right. Thank you so much. Have fun. Can you stop the recording? Oh.
I did it. Well, let's see how many. I would have to go to my Google Forms.